Thank you everyone for joining our special ceremony for the 10th TCTAP Award Master of Masters 2020. Since 2011, we have bestowed Master of Masters upon who has made a remarkable contribution to the field of intervention cardiology and to the growth of TCTAP as well. So far, we have given the Master of Masters Award to 10 masters, and I would like to sincerely express my appreciation to them for their hard work and dedication on the behalf of all cardiologists and the TCTAP and AP Valves Committee. The past recipients are Dr. Masaki Nobuyoshi, Marie Leon, Antonio Colombo, Gary Minch, Spencer King, Barry Rutherford, Edward Gruber, David Holmes, and Professor Patrick Saruiz last year. And I would like to introduce the next hero for 10th Master of Masters Award.
Over the past 2 decades, I truly believe that Gregg Stone has been among the premier clinical trialists in evidence-based medicine and interventional cardiology, and has made enormous contributions to the field that have been truly practice-changing.
Gregg has made many contributions to interventional cardiology, but the one that stands out, of course, is his contributions in clinical trials, the design, the execution of those trials that have made major impact on our specialty.
His fields of interest have been broad and included all of cardiovascular disease, both from those patients that have chronic angina, to the treatment of complex coronary artery disease, to new technologies such as biovascular scaffolds, to the evaluation and treatment of patients with mitral regurgitation, such as the recent COAPT trial.
What he contributed in the context of the COAPT trial is a milestone. Gregg is not only a scientist, but he's a well-rounded interventionist with knowledge in real-life interventions.
Gregg is a master of hard working. He is constantly working hard to improve himself and the science by taking on new challenges and thinking through even simple questions to find a different or better way to approach a challenge.
You are undoubtedly, with Marty, the two most influential interventional cardiologists worldwide. Your knowledge of the field is encyclopedic, and your track records in publication are phenomenal.
Most academic interventional cardiologists would be proud if they have published one or two New England Journal of Medicine first author or senior author paper. At last count, I think I've got about 18 to 20 papers that you have published as first or senior author in the New England Journal of Medicine. It's clear that your contribution goes beyond interventional cardiology and is a major achievement in medicine as well.
This award acknowledges your outstanding work and research in the field of cardiology in general and in the field of coronary heart disease and structural heart disease in particular. You have always been adamant in the research of these fields, and you are looking to find answers, scientifically based answers to many open questions in coronary disease and of course in structural disease.
I just want to take a moment to offer my most heartfelt congratulations to Professor Gregg Stone. He's been a colleague and a friend and a mentor to me. So much of what I've been able to achieve is through his guidance and his ability to enable me to make the right decisions about not only career, but the types of clinical trials that I was involved in.
You also have been a huge contributor to the growth of CBRF, TCTAP, since 2000. I am grateful for your support and advices you've given to establish a better and informative meeting.
Congratulations, Gregg, for being awarded the 10th TCTAP Master of the Masters Award.
It's a pleasure to give this on behalf of Dr. Gregg Stone.
Thank you for your leadership and friendship.
Congratulations for receiving the 10th Master of the Masters Award.
Heartfelt congratulations to you, Gregg.
Gregg, congratulations.
Congratulations, Gregg.
Congratulations.
Again, my special and sincere congratulations to Gregg in being this year's recipient of the TCT Asia Pacific Award.
So the impact that we can have on people's lives is, I think, the most special reason to be a human being. And as an interventional cardiologist, I'm humbled to again have been able to enter into many people's lives and be shown the trust to be able to help them. Rely on many other people, don't try to be your own island, but also try to be very cognizant as you're going through this life how special it is, and that you are having such a wonderful chance to help so many people. And then you will be very, very happy. Don't be motivated by money, don't be motivated by stature, but be motivated by the chance to interact with and affect the other people's lives, and then you will feel very, very satisfied in your life.
Hello. I can't thank you possibly enough for giving me this great honor, recognizing me as the 10th Master of the Masters. Coming from S.J. Park and all the course organizers at TCT Asia Pacific, this means so much to me. I really can't express my feelings. The way I think about it, we're all here for a very short period of time on this earth, and all I've ever wanted to try to do in my professional career is make a difference for the lives of as many people as possible. Initially with all the patients that I care for as an interventional cardiologist, then secondary as a researcher to come up with new discoveries that would affect not only the hundreds or thousands of patients that I can individually reach, but that all cardiologists and all physicians can take those lessons and apply to their patients. And then finally, one of the greatest honors of my life has been to mentor so many young students, fellows, interns, residents, junior faculty, really helping to create the next generation of interventional and academic physician scientists. Again, to be acknowledged by TCT Asia Pacific for this career's worth of work, which I hope is not over yet, is just extraordinary and is truly one of the greatest awards and acknowledgments I've ever received in my life, that all the hard work and all the giving up family time and other hobbies, etc., has been worth it and at least has been appreciated, which is always a nice acknowledgement to have. Finally, the bust that I received was beautiful, and I'm going to honor it. It's going to be in a very special place in my study, and here you can actually see it. I'm going to go down a little bit. It's over there in the back. It looks small in this picture, but I can guarantee you it's very large. It's extremely impressive, and you've done a good job, I think, connecting capturing my likeness. Perhaps you've given me more hair than I have, and I think that as I look at this bust over the years, it's going to be very fun to remember those days. So SJ and all your colleagues, thank you again. I could not be more thrilled and touched by this award, and it will mean something very, very special and important to me for the rest of my life. Hi. It's really my pleasure today to deliver this special lecture, PCI and CABG for left main disease, different procedures with different outcomes. These are my disclosures. I have no direct financial relationships with any stent manufacturer. So when we talk about left main coronary artery disease, this obviously is a very important subject because the left main can supply 70% or more of the left ventricular myocardium. And of course, there's a variety of left main disease, from very simple disease to very complex disease involving the distal bifurcation, and it can be associated with either 0, 1, 2, or 3 vessel coronary artery disease. Now, until recently, bypass surgery was the gold standard treatment for left main coronary artery disease. But that started to change really with the Syntax trial. And as you recall, the Syntax trial randomized patients with either triple vessel disease or left main disease to either bypass surgery versus first generation Taxus drug-eluting stents. And the outcomes were quite different. The multivessel patients tended to do better with surgery, but the left main patients did quite well with even first generation Taxus DES. So if you look here at the 705 randomized patients in the left main subset, and this was a separate randomization, following the patients out to 5 years, there was no significant difference in the primary endpoint of death, myocardial infarction, stroke, or repeat revascularization between Taxus and surgery. But of course, we learned that for PCI in particular, the Syntax score has a tremendous effect on outcomes. So in patients with left main disease and lower intermediate Syntax scores, you could see the MACCE event rates were almost identical between PCI and surgery, and in fact, mortality actually tended to be lower. In contrast, in patients with high Syntax scores, the outcomes were clearly better with surgery compared to Taxus drug-eluting stents. Now, since the Syntax trial, there have been many advances in PCI, in procedure equipment and the technique. The stents got better with thin strut, durable, and bioabsorbable polymer-based DES that were more biocompatible than that in the original Taxus and Cypher stents. Improved guide wires, delivery systems, and adjunct devices. Outcomes being improved in many patients with radial intervention. Better hemodynamic support options when necessary. And importantly, pre- and post-procedure guidance with either physiologic lesion assessment and or intravascular imaging. The pharmacotherapy has gotten better, and we've gotten much better selecting the right patients. So some would argue that the results of the Syntax trial no longer apply in 2020. And in addition, bypass surgery outcomes have continued to improve as well. So with this in mind, we designed the EXCEL trial. And EXCEL is the largest randomized trial to date of patients with unprotected left main disease. We actually screened a total of 2,905 patients, and those with a syntax score visually estimated of up to 32, that is lower intermediate, in whom there was equipoise for revascularization, were randomized to either PCI with Xience everolimus-eluting stents or bypass surgery. And Xience, of course, has a very biocompatible polymer, and everolimus, and it's a thin strut cobalt chromium stent, so it's still a contemporary state-of-the-art stent. So a total of 1,905 randomized patients with 1,000 additional patients followed in an enrollment registry. And with this many randomized patients, we were the first trial to be adequately powered for the triple composite endpoint of death, MI, or stroke, measured at a median follow-up of 3 years. Again, acknowledging the fact that repeat revascularization is an endpoint of much less important than death, MI, and stroke, arguably no more important than atrial fibrillation or kidney disease or many other endpoints we could have chosen. But everybody would agree that death, large MI, and stroke are important endpoints. Now, the syntax scores in this trial were supposed to be low and intermediate, and by the site-reported analyses they were, but by the core lab, the sites tended to underestimate the syntax scores, and you could see actually a quarter of the patients enrolled had high syntax scores. So the primary endpoint was all-cause death, stroke, or MI at a median of 3 years, and this occurred in about 15% of patients in both groups, as we reported in the New England Journal of Medicine. But early on, you could see that PCI was associated with fewer adverse events than CABG, and then there was a catch-up by the time you got to 3 years. And those trends continued as we followed up patients to 5 years. So at 5 years, 22% of patients after PCI had an adverse event versus 19% of patients after surgery, a 3% or 2.8% difference, which was not statistically significant. Now, when we looked at the primary 5-year endpoint, according to a whole number of pre-specified subsets, this is a very busy slide, but I'll summarize. If you look at some of the important subgroups, there was really no difference in relative outcomes according to whether diabetes was present or not. There was no difference according to whether the left main bifurcation or trifurcation was involved versus not. That was about 80% of patients. There was no difference as to whether in additional left main disease, there was 0, 1, 2, or 3 diseased coronary arteries. You could see even with triple vessel disease, the outcomes were very similar. And similarly, even with the syntax scores assessed by the core laboratory, there was no significant difference between CABG and PCI with everolimus-eluting stents, according to low versus intermediate versus high syntax score. So there were no interactions with any subgroup that we were able to identify. So how does one interpret the results that look like this, where the curves are crossing? This is what's called non-proportional hazards. And you can see early on, the outcomes were better with PCI, but then later on, with the curves crossing and continuing to diverge, the outcomes were better with CABG. Well, we could look at the area in between the curve, the so-called restricted mean survival time, and this is really the disease-free burden that each patient is experiencing. And of course, if you're going to have a complication, you'd rather have it early than late. So when you do this overall, it turns out that there's about a 5-day difference favoring PCI, but the outcomes are statistically not significant. So overall, the disease-free burden is very similar after PCI and CABG. Now let's dive down a little deeper. When we get into 30-day outcomes, you could see that there's about a 40% reduction in adverse events. Death rates were very low after PCI and CABG. Stroke rates in hospital were fewer after PCI, but by 30 days, the trend towards a 50% reduction was no longer significant. The big difference favoring PCI over CABG in 30 days was a reduction in large myocardial infarctions, particularly ST segment elevation MIs, and this was really because the rate of stent thrombosis with Xience everolimus-eluting stents were very low, only 0.6% compared to a 1.2% rate of symptomatic graft occlusion. So the therapy, if you will, failed higher or more frequently after surgery compared to PCI in the first month. Now, we also had a pre-specified endpoint called major adverse events. And this is the surgical and interventional leadership of the Excel trial agreed that these were important adverse events to track. In addition to death, stroke, MI, and repeat revascularization, there was major bleeding, transfusions, atrial or ventricular arrhythmias requiring treatment or anticoagulation, additional surgical procedures, acute renal failure, sternal wound dehiscence, sepsis, prolonged intubation, etc. And you can see there was a marked reduction within the first 30 days in overall adverse events with PCI compared to surgery. 12.4% versus 44%, a 72% reduction, with almost all of these favoring PCI. So everyone knows that PCI is less procedural morbidity than surgery, but this kind of really quantitates it. Now, when we look at 5-year outcomes, though, we see a different picture. And here you can see the death, stroke, or myocardial infarction. The absolute difference of 2.8% is not statistically significant. But you'll note also you don't see any p-values on this slide. And that's because the New England Journal now has basically said we're not going to show p-values anymore for secondary non-powered endpoints. And of course, all the 5 years endpoints were not powered. And none of these have been adjusted for multiple testing. On the other hand, if you look, you do see that there was an excess in mortality. It's about a 3% difference, but if you look at the confidence interval, this was a slight increase. Now, there was no difference in cardiovascular mortality, and similarly, there was no difference overall in myocardial infarctions. And that makes sense because you would expect the greater cardiovascular mortality, if it did exist, to perhaps be driven by more MIs, and we didn't see that. Instead, the difference was really in non-cardiovascular deaths. And if you look at the detailed causes of these non-cardiovascular deaths, it was mostly infections due to sepsis and cancers, all occurring beyond 1 or 2 years after the procedure. So it really lacks biologic plausibility that these deaths would be related to the procedure, most likely meaning it's due to play of chance. Now, when we look at cerebrovascular events, you can see that there were fewer cerebrovascular events after PCI compared to surgery, but in contrast, there were more ischemia-driven repeat revascularizations after PCI compared to surgery. Now, regardless of whether or not you want to believe that some of these differences are true or not, you can see that the absolute differences over a 5-year time perspective, ranging from about 1 to 7%, are all pretty small. So the differences between these procedures have gotten, even if there are still some that exist, have gotten really very minimal. We also had a formal quality of life sub-study, and as you can see, within the first 30 days, patients immediately felt better after PCI, but they actually felt worse after surgery. Again, surgery is a difficult procedure to go through. But by 1 year and by 36 months, you could see quality of life in terms of at least physical summary and functioning is identical. And we saw something similar with mental status and with angina frequency. Both procedures were very good at relieving angina, although maybe within 30 days, PCI a little bit better, but then at 12 months and 36 months, very similar relief of angina after PCI and surgery. So it really comes down to this big issue of death, because one could argue that for any procedure, the two reasons to do it are to, 1, prolong survival, and 2, improve quality of life. And I think I showed you very convincingly that the quality of life is very similar between these two procedures. But what about that borderline mortality difference? Well, when you're looking at underpowered secondary endpoints, it's important to look at the totality of the data. And we've actually had 5 randomized trials with 4,612 patients, and this recent meta-analysis reported at a mean 5.6-year follow-up, and you can see there's absolutely no difference in mortality between PCI and CABG for left main disease. You will note here that there is moderate heterogeneity between these studies, an I-squared value of 42.9, and that was all because of Excel. And in fact, if Excel was removed, there's absolutely no difference in mortality with a relative risk of 0.93, slightly favoring PCI, but not significant. So Excel was the outlier, and the aspect of the outlier was those non-cardiovascular deaths due to cancer and sepsis, which likely were just play of chance. And in fact, if you say don't bore me with statistics, here are the curves of the 4 large trials of left main PCI versus DES, the 5-year follow-ups, and you could see that they're very similar. In one study, the blue line slightly above the red line, another study, the red line slightly above the blue line, but these are very similar.
Well, what about longer term follow-up than 5 years? We always hear that with long-term follow-up, that's when PCI will continue to fail, but surgery won't. Well, we now have 2 of the studies that have gone out 10 years, and here's the Syntax trial at 10 years, and you can see absolutely no difference between PCI and CABG in mortality. In fact, if anything, the point estimate is slightly lower for PCI. And here's the pre-combat trial now at 10 years, no difference in overall mortality, maybe this point estimate slightly favoring CABG. So really, and you note that the curves don't diverge at all between 5 and 10 years. So whatever you get early on is when you're going to get long term. So in the bottom line, you need to have a heart team discussion with the patient to describe the fact that PCI and CABG for left main disease are 2 very different procedures. PCI has early advantages. It's less invasive, it has fewer periprocedural complications such as stroke, MI, AFib, bleeding, acute kidney injury, etc., and therefore it's got lower 30-day MACE. It's got more rapid recovery with better early quality of life and earlier angina relief. On the other hand, surgery also has benefits. It's a more durable procedure. There are fewer adverse events beyond 1 year, particularly myocardial infarctions and late repeat revascularization procedures. Overall, at the end of the day, there are no significant major differences in long-term survival, overall composite MACE, or quality of life. So patients need to understand the differences between PCI and CABG, and depending on their specific clinical and anatomic characteristics and patient preferences, one or the other procedure may be more indicated for each individual patient. A decision that should be made with the heart team and the patient. Thanks very much, and I look forward to seeing everybody again soon.